Good day, batch 2025. My name is Ma'am Marilyn Martinez. I am a faculty member in the Physical Therapy Department and also one of the facilitator of the ANA 212 subject. At the same time, I am the topic organizer for this module, Shoulder Complex and Elbow, and I will be narrating the recorded lecture for this module. The recorded lecture is divided into two parts. We have first the shoulder complex, and the second part will be talking about the elbow complex or the elbow area. So I suggest, guys, that you browse the list of references that I have given to you and also the handouts that I have given to you. So answer the handouts while browsing the references and also while reviewing this presentation. At the same time, I am also suggesting, highly encouraging you guys to open the complete anatomy and study with that application because it has a good visualization of the structures composing your shoulder complex and the elbow. The first part of this recorded lecture will be focused on the shoulder complex. So this is the topic content of the shoulder complex presentation. So we will be discussing about the bones of the shoulder complex, the joints, the shoulder bursae, the scapulohumeral rhythm, the muscles that is composing the shoulder complex, the stabilization of the glenohumeral joint, and there are also movement analyses for us to discuss the application of our knowledge about osteokinematics, arthrokinematics, and that muscle and the type of contraction during those movements. And lastly, we have the case analysis for us to apply what we have learned for this presentation. For the bones and the muscles, I will not be discussing it comprehensively because these are already in your handouts and at the same time available in your references. So I suggest again that you browse the handouts and the references while reviewing this recorded presentation. We have four bones composing the shoulder complex. First, we have the sternum. It is a flat bone that lies in the midline of the anterior chest wall, which is actually not seen in this picture. Next, we have the clavicle. So this is the clavicle. By the way, the picture is in the posterior view. So this is your clavicle. It is the most commonly fractured bone in the body. We also have the scapula that is triangular in shape, located posteriorly, and the humerus, specifically the proximal to mid humerus. So our first bone is the sternum. Again, I will not be discussing the bony landmarks comprehensively in this recorded lecture because the descriptions, the clinical significance, and the importance of these bony landmarks are already in your handout. And it is actually part of your assignment to fill it up by browsing and reading the references, the list of references that I have given you. So what we will be doing now is to identify some of the important bony landmarks in this picture. And as you can see, I have utilized a different picture. This is different from the pictures available in the list of references that I have given you, and it is also different from the models available in the complete anatomy. These are actually pictures of real bones. Okay, so let's start. This is the anterior view, posterior view, and lateral view of the sternum. So the sternum is actually divided into three parts. We have the manubrium, the body of sternum, and the xiphoid process. So in the manubrium, we have your jugular notch or your sternal notch. Actually, this is palpable. So you may try and palpate it in your body. Next, we have this area, which is the clavicular notch. So this is where the clavicle articulates with the sternum to form the sternoclavicular joint. Next, we have the sternal angle or the angle of fluid or the manubriosternal joint. Your angle of fluid is an important landmark because this is used to actually this is a guide to actually identify the other anatomical landmarks in this area. Because adjacent to your manubriosternal joint or to your sternal angle is the notch for the second costal cartilage of the second rib. So meaning once you identify this area, because this is palpable also in our body, you can already conclude that the rib adjacent to it is the second rib. Now you can count the other or the succeeding ribs. Or you can identify now the location of the other ribs. Because the first rib is usually very difficult to palpate. So with that, the notch adjacent to the angle of Louis is the notch for the second costal cartilage of the second rib. So another clinical significance of the angle of Louis is that it is one of the landmarks that physical therapists use when performing chest expansion measurement. As you know, physical therapists also perform different tests and measures in order to examine their patient. And one is chest expansion, which will be further discussed on your examination and evaluation and documentation subject next semester. But for now, please remember that the angle of Louis, it is palpable and it is one of the bony landmarks, or it is one of the anatomical landmarks that we use when measuring the chest expansion of our patient. So let's proceed. Next, we have the different notch for the different costal cartilages of our ribs. So here specifically, we have the notch for the third costal cartilage of the third ribs, fourth, notch for the fourth costal cartilage of the fourth rib, notch for the fifth costal cartilage, and notch for the sixth costal cartilage of the sixth rib. Then, again, we have the xiphoid process in this one, and the joint connecting the xiphoid process to the body of sternum, your xiphisternal joint. Next, we have the clavicle. So one function of the clavicle is that it transmits forces from the upper limb to the trunk. And actually, we can associate that on one of the reasons why the clavicle is the most commonly fractured bone in the body. Because, for example, if a person falls in his or her outstretched hand, or if the person falls on his or her shoulder, or basically if there is an impact around his upper limb, the clavicle has to accept all those forces from the impact. Because the clavicle has to transmit those forces from the upper limb to the trunk of the person. And as you can see, it is commonly fractured because the clavicle is a slender bone. A slender bone that has to accept all the forces transmitting from the upper limb to the trunk. And if we are to divide our clavicle into three, 1, 2, the most common location of fracture will be the weakest point of the clavicle. And the weakest point of the clavicle is between the connection between the middle 1/3 of the clavicle and the lateral third of the clavicle. So if we are to identify here in our clavicle, this area is the weakest point of this clavicle because this is the connection between the middle thirds of the clavicle and the lateral thirds of the clavicle. Now, ma'am, how did you know that this is the middle thirds and this is the lateral end or the lateral third of the clavicle? For us to know the orientation of a clavicle, we have to always remember that a clavicle is composed of a medial 2/3 convex anterior surface and a lateral 1/3 concave anterior surface. Okay, so if we are to follow this division, by the way, this is in the inferior view. Okay, so this is the view of the clavicle from below. So if we are to follow our division, first dividing the clavicle into 3, we can say now that this area is the 2/3 of the clavicle that is in convex and this area is the area of the clavicle that is 1/3 and concave. So we can now assume that this is the anterior surface of the clavicle, and since this is the convex 2/3, this is the medial side of the clavicle, and this is the lateral end of the clavicle. We cannot say that this is the um, anterior surface of the clavicle, because if you will compare the concave surface of this side of the clavicle, it is 2/3. 2/3 of the clavicle. 2/3 of the clavicle. And as to the convex area, it is just 1/3 of the clavicle. So this is the posterior area of the clavicle, and this is the anterior area of the clavicle. And if this is the medial side of the clavicle, therefore, this is now the sternal end of the clavicle that articulates with the sternum to form the sternoclavicular joint. And this one is the acromial end of the clavicle that articulates with the acromion of the scapula to form the acromioclavicular joint. On the inferior surface of the clavicle, we have a roughened surface known as your costal tuberosity, which serves as an attachment for the costoclavicular ligament, a ligament that is attaching the clavicle and the first rib together. Then next we have a tubercle on the lateral side of the clavicle, specifically your conoid tubercle, which serves as an attachment of the conoid ligament. And around this area is your trapezoid line, which is also an attachment for your trapezoid ligament. So all the ligaments that I have mentioned will be further discussed on the joints of the shoulder complex. If the previous slide showed the inferior view of the clavicle, now we have the superior view of the clavicle. So again, this is the sternal end of the clavicle that articulates with the sternum. And as you can see, we have the acromial end of the clavicle that articulates with the acromion of the scapula to form the acromioclavicular joint. Then we have the shaft of the clavicle. Next, we have the posterior view of the scapula and the anterior view of the scapula. How did I know that this is the posterior and this is the anterior view of the scapula? First, look for the spine of the scapula. The spine of the scapula, this one is always located posteriorly, just like our spine of the body, which is always located posteriorly. So with that, this is the spine of the scapula. So as it goes superiorly and laterally, it now becomes the acromion process, which articulates with the clavicle to form the acromioclavicular joint. Next, we have here the coracoid process, then the margin of the glenoid fossa. Margin of the glenoid fossa. So the glenoid fossa, again, it articulates with the humeral head to form the glenohumeral joint. Therefore, this side is the lateral side. This side is the lateral side. If this is the lateral side, then this is the lateral border of the scapula, inferior angle of the scapula, medial border of the scapula, the superior angle of the scapula, and the superior border of the scapula. Superior border of the scapula, superior angle of the scapula, medial border, inferior angle, and lateral border of the scapula. We have here your supraspinous fossa, supra above the spinous spine. So it is located above the spine of the scapula, and your infraspinous fossa. Infra below spinous spine, so it is located below the spine of the scapula. On the anterior view, we also have your subscapularis or subscapular fossa, which is an attachment for the subscapularis muscle. Your supraspinous fossa is an attachment for your supraspinatus, and your infraspinous fossa is an attachment for your infraspinatus muscle. Next, we have here the lateral view of the scapula, just to give emphasis on the glenoid cavity or the glenoid fossa of the scapula. which articulates with the humeral head to form the glenohumeral joint. So the tubercle located above or superior to the glenoid cavity or glenoid fossa is your supraglenoid tubercle, which is an attachment for a specific muscle that you have to identify in your handout. And we have here another tubercle located inferior to the glenoid cavity or glenoid fossa, so that is your infraglenoid tubercle, which is again an attachment for a specific muscle that you have to identify in your handout. Next, we have the humerus, specifically the proximal to mid humerus. So this is the anterior view, posterior view, medial view, lateral view, and a superior view to give emphasis on the humeral head and other structures on the area. So first, we have here your humeral head, the anatomical neck. So the anatomical neck connects the humeral head to the shaft of the humerus. Then if we have the anatomical neck, we also have the surgical neck. So it is called surgical neck because it's prone to fracture. So the surgical neck connects the proximal or the upper humerus to the shaft of the humerus. Next, we also have here the tubercles or the tuberosity. So we have the greater tuberosity and the lesser tuberosity, or the greater tubercle and the lesser tubercle. And in between them is the groove, the bicipital groove, which houses a specific tendon that you have to identify in your handouts. This is also called your intertubercular groove because the groove is between the two tubercles. Okay, so if we are to look on the superior view of the humerus, as you can see, this is the humeral head, this is the bicipital groove, then this is the lesser tuberosity, this is the greater tuberosity. And if you look closely on the greater tuberosity, we have here your three facets. So we have the upper facet, the middle facet, and the lower facet. So these facets are actually attachments of muscles that you have to identify in your handouts. Clue, they are rotator cuff muscles. Then also with your lesser tuberosity, it is also an attachment for a specific muscle that you have to identify. Let's go back on the posterior view. So this is the intertubercular groove, and located medial to it is the medial lip of the intertubercular groove, and lateral to it is the lateral lip of the intertubercular groove. So these medial and lateral lip are actually also attachments of muscles that you have to identify in your handouts. Then lastly, we have here an area. So this is the groove for the radial nerve or your spiral or radial nerve. And actually, since the radial nerve passes in this area, this is a common site of injury for the radial nerve. Again, this is the spiral groove or the radial groove. With a surgical neck, again, it is called surgical neck because it is commonly fractured. And the axillary nerve is closely located in the surgical neck. Therefore, sometimes if there is a fracture on the surgical neck, the commonly injured nerve or the associated injury will be an injury to the axillary nerve because of its close proximity with the surgical neck. We are now done with the different bony landmarks of the different bones of the shoulder complex. Let's now proceed with the orientation and alignment of these bones. We will be discussing four angles for this part. So first we have the orientation of the clavicle. So this is the superior view of our body and this is the clavicle. So as you can see, the clavicle is deviated at about 20 degrees posterior to the frontal plane. So just to review, this is the frontal plane, this is the sagittal plane. So As you can see, the clavicle is tilted or deviated 20 degrees posteriorly to the frontal plane. For the orientation of the scapula or the scapular plane, it is also deviated to the frontal plane. Specifically, it is deviated 30 to 40 degrees anterior to the frontal plane. Again, for the clavicle, it is deviated 20 degrees posterior to the frontal plane. Then for the scapular plane or the orientation of the scapula, it is deviated 30 to 40 degrees anterior to the frontal plane. Next, we have the angle of torsion of the humeral head. As you can see, the humeral head is deviated posteriorly to the medial lateral axis at the level of the elbow. When we say medial lateral axis, it is the axis that passes through the sagittal plane. It is also known as your x-axis. If you can remember, this is your x-axis, this is your y-axis, right? So, in here, the humeral head is deviated 30 degrees posteriorly to the medial lateral axis that passes through at the elbow joint. Okay, so this is another visualization of the angle of torsion of the humeral head. Again, the humeral head is deviated or it faces 30 degrees posterior to the medial lateral axis at the level of the elbow, or the medial lateral axis that passes through the elbow. Since it is deviated posteriorly, that's why it is also called retroversion of the humeral head. So, this retroversion of the humeral head allows the humeral head to align with the glenoid fossa while still maintaining the elbow and hand in the functional position. Next, we have the angle of inclination. So we have two angles involving the head of the humerus. First is the retroversion and the other one is this, the angle of inclination. So according here, the humeral head faces medially and superiorly. So for me to easily remember the orientation of the humeral head, I think of Superman, because as you can see, for Superman to fly, he has to flex his shoulders. So he has to move his humerus, humeral head, Superman, humeral head, Superman. So the orientation of the humeral head is Superman, superior, posterior, and medially. Okay, orientation of the humeral head, superiorly, posteriorly, and medially. So, superiorly and medially, it now forms an approximately 135-degree angle with the long axis of the humeral shaft. For the posteriorly, you can correlate it with the retroversion of the humeral head, which was discussed in the previous slide. So again, angle of inclination, the head of the humerus is oriented superiorly and medially, forming a 135-degree angle in relation to the long axis of the humeral head. So again, orientation of the head of the humerus is superiorly, posteriorly, and medially oriented. Next, we have the alignment of the glenoid fossa. So according here, your glenoid fossa is tilted approximately 5 degrees upward in relative to the scapula's vertebral border or medial border. So if we are to analyze that, this is the medial border of the scapula. So let's copy the orientation of the middle border of the scapula around here. So they said, or the alignment of the glenoid fossa is actually tilted approximately 5 degrees upward in relative to the scapula's vertebral border. So actually, this helps in the stability, or this contributes in the stability of the glenohumeral joint. We are done with the bones of the shoulder complex. Now let's proceed with the joints of the shoulder complex. As you can see, we have 1, 2, 3, 4, 5, 6. Yes, we have 6 joints composing the shoulder complex. The joints of the shoulder complex are divided into two categories. We have the true joints and the false joints. When we say true joints, they are true joints because they have true bone-to-bone articulations. On the other hand, the false joints are considered false joints because they do not have true bone-to-bone articulation. So under the true joints, we have your sternoclavicular joint, acromioclavicular joint, and your glenohumeral joint. For the false joints that do not have true bone-to-bone articulation, we have your scapulothoracic joint, suprahumeral joint, and your bicipital groove or your intertubercular groove. The first joint of the shoulder complex is the sternoclavicular joint or the SC joint. The SC joint functions as the basilar joint of the entire upper extremity. Why? Because it links the appendicular skeleton. When we say appendicular, it's extremity. So it links the skeleton of the upper extremity with the axial skeleton or the skeleton in the trunk area. Therefore, the joint must be firmly attached while simultaneously allowing considerable range of motion in the upper extremity. Now, for it to be stable and for it to be able to allow considerable amount of movement at the same time, it is surrounded by different periarticular tissues such as ligaments and the capsule. At the same time, the shape of the sternoclavicular joint helps in this ability or in this function. As to the articulating surface, we have the sternal end of the clavicle and the clavicular facet of the sternum. Specifically, as to the shape, we have two shapes per articulating surface. So we have the convex shape on the longitudinal diameter of the sternal end of the clavicle, and as to the transverse diameter of the sternal end of the clavicle, it is concave. On the other hand, for the sternum, just reverse the shape of the articulating surfaces of the clavicle. So with that, for the clavicular facet of the sternum, the longitudinal diameter is concave in shape to articulate with the convex articulating surface of the clavicle, and as the transverse diameter, it is convex to articulate with the concave articulating surface of the clavicle. So if we are to ask, or if you are to ask the type of joint, this is saddle. Saddle, synovial, and diarthrodial. In general, the articulating surface of the sternoclavicular joint is the medial end of the clavicle, the clavicular facet of the sternum, and also the superior border of the first costal cartilage. When we say first costal cartilage, that is the cartilage of the first rib. So when you say second costal cartilage, that is the costal cartilage of the second rib. So let's proceed now with the periarticular connective tissues of the sternoclavicular joint. So the SC joint is enclosed by a capsule and is reinforced by the different periarticular connective tissues such as the ligaments and the muscles. Let's proceed first with the ligament. So first we have the anterior and posterior sternoclavicular ligament. From the name itself, sternoclavicular, so its attachments are the sternum and the clavicle. So we have one ligament that is located anteriorly, anterior sternoclavicular ligament, and another ligament that is located posteriorly, posterior sternoclavicular ligament. So these ligaments blend with the joint capsule of the SC joint. Next, we have the interclavicular ligament. Interclavicular, so between the clavicles. So as to the location, it is located between the two clavicles and runs the span of the jugular notch. Remember, this is your jugular notch. So it connects the medial end of the right and the left clavicles. Next, we have your costoclavicular ligament. Your costoclavicular, so from the name itself, attachments will be costal cartilage, specifically the first costal cartilage and the clavicle, specifically the costal tuberosity located in the inferior surface of the clavicle, which we have discussed a while ago. Based on the picture, it has two fibers. We have, or two bundles. We have the anterior bundle and the posterior bundle. So the anterior bundle, as to orientation, runs obliquely, superiorly, and laterally. Again, it runs obliquely in a superior, so up, and lateral direction. For the posterior bundle, its orientation, it runs obliquely in a superior and medial direction. Okay. Aside from ligaments, we also have the muscles surrounding the sternoclavicular joint. So when these muscles are active, it adds further stability to the joint. Specifically, your SCM, which is located anteriorly. So it provides support in the anterior aspect of the joint. As to the posterior aspect of the joint, we have the sternothyroid and the sternohyoid, and the inferior part will be protected by the subclavius. So just browse your complete anatomy in order to locate those muscles. Next, we have here your articular disc. Your articular disc is a flattened piece of fibrocartilage. So this not only strengthens the articulation but also functions as a shock absorber by increasing the surface area of joint contact. Of course, if you increase the articulating surface of the joint, you also decreases the force of or the impact received by each square area of the articulating surface of the joint. Therefore, the articular disc as a shock absorber within the joint. So this absorption mechanism is actually good, and if you will correlate it with the different medical conditions related to the sternoclavicular joint, the age-related degenerative arthritis actually is rare in this joint, and one reason will be the presence of the articular disc that serves as shock absorber in the area. So aside from that, your articular disc also reduces the risk of the clavicle sliding over the manubrium. So anatomically, your articular disc separates the sternoclavicular joint into two cavities. We have the lateral cavity and the medial cavity. So the medial cavity has the sternum and the lateral cavity has the clavicle. As to the anatomy, each attachments will be the inferior part of the sternum and the superior part of the clavicle and the interclavicular ligament. Let's proceed with the specific functions of the different ligaments surrounding the sternoclavicular joint. So first we have the anterior and posterior sternoclavicular joint ligament. So it protects against anterior and posterior joint stresses. If you'll review the anatomy, they are located anteriorly and posteriorly, and therefore limits protraction and retraction of the clavicle. So for you to better visualize how these ligaments limit those movements, I have here a video. So the first video shows or will show how the clavicle is whenever there is protraction of the clavicle. So this is again protraction of the clavicle. So when the clavicle protracts, there is anterior gliding. So there is anterior gliding of the clavicle. Therefore, at the SC joint, therefore, the posterior sternoclavicular ligament will now limit excessive protraction. Okay, why? Because the posterior sternoclavicular ligament is located here. So, if it is located here, it will prevent there. Okay, it will limit excessive protraction of the clavicle. So now let's proceed with the retraction of the clavicle. So the retraction of the clavicle at the SC joint is limited by the anterior sternoclavicular ligament, which is located here. So let's try to draw. There, it's located here. Okay, so whenever there is clavicular retraction at the SC joint, the clavicle slides posteriorly. That's why the ligament that limits clavicular retraction is the anterior sternoclavicular ligament. So let's play the video to be able to better visualize this one. Okay, as you can see, there you go. Retraction of the clavicle limited by the anterior sternoclavicular ligament. Your interclavicular ligament prevents upward clavicular displacement at the SC joint. So how? Remember, this is your interclavicular ligament. So if there is upward displacement of the clavicle, your interclavicular ligament, which spans in the jugular notch, will be able to limit excessive upward displacement of the clavicle. Okay, because it is located in this area. Next, we have the costoclavicular ligament. So this is your costoclavicular ligament. It assists with stabilizing the joint through all motions except for downward movement of the clavicle or depression of the clavicle. Why? Okay, so for example, this is your costal cartilage. Okay, for a while. This is your first costal cartilage. This is your clavicle in normal position. Then this is your costoclavicular ligament. Still slack, still not tightened because it is in the normal position. So if there is upward displacement of the clavicle, for example, upward displacement, so the clavicle will be displaced around here. I'm gonna make it excessive for you to better visualize. Now, it will tighten the ligament, therefore preventing or stabilizing all motions of the clavicle, except depression of the clavicle. Why? So if there is depression of the clavicle, so this is the clavicle, this is the clavicle again. So if there is depression of the clavicle, therefore, the clavicle will be displaced downward. So let's try to do that around here. What will happen to the ligament between the clavicle and the first costal cartilage? Will it be tightened or it will be lax? It will be lax, okay? So let's try to draw it. Therefore, it will not be able to limit the depression or downward displacement of the clavicle. Unlike, for example, if it's during upward displacement of the clavicle, it will tighten because you are moving the attachments of the ligament away from another. Therefore, excessive anterior displacement of the clavicle will be now limited by this ligament. So I hope that is clear. So overall, your costoclavicular ligament restricts clavicular elevation, rotation, and medial and lateral movement. So basically, all movements of the clavicle except again for downward displacement. So overall, your periarticular connective tissue strengthens the joint. That is why when large forces travel from the upper extremity and the clavicle to the SC joint, the clavicle fractures first before the SC joint dislocates. Okay, it's because of these periarticular connective tissues that provide stability in the sternoclavicular joint. And that is also one reason on why the clavicle is the most commonly fractured bone in the body. Osteokinematics of the sternoclavicular joint. So we have 5 movements available for the sternoclavicular joint, specifically elevation, depression, retraction, protraction, and posterior rotation or upward rotation of the clavicle. Ma'am, why is anterior rotation not included here? The reason for that is because anterior rotation only happens after posterior rotation when the clavicle is returning to its resting position. That is why it's not considered here. As to the degrees of freedom of the sternoclavicular joint, we have three. Why three? Because the movements available for the sternoclavicular joint happens in all three planes. So specifically, elevation and depression happens in the frontal or coronal plane with the z-axis or the anterior posterior axis as its axis of rotation. Next, retraction and protraction happens in the horizontal plane or the transverse plane with the axis of rotation y-axis or vertical axis. Then lastly, the posterior rotation or the upward rotation or the axial rotation or the longitudinal rotation, they are all the same, happens in the sagittal plane with the x-axis or the medial lateral axis as the axis of rotation. So let's just discuss briefly the different movements in the sternoclavicular joint. Your elevation and depression happens happens between the sternal end of the clavicle here and the articular disc. Remember, the articular disc divides the sternoclavicular joint into two cavities. So we have the lateral part and we have the medial part. So elevation depression takes place between the sternal end of the clavicle and the articular disc. On the other hand, your retraction and protraction, it happens between the sternum and the articular disc. Again, your protraction and retraction happens between the sternum and your articular disc. For the posterior or upward rotation, it is actually a passive motion. Ma'am, bakit po siya? Why is it passive motion of the clavicle? Because the movement of posterior rotation of the clavicle only happens when there is tightening of the acromioclavicular ligaments, that is your trapezoid and your conoid ligament. Okay? Again, that is your conoid ligament and your trapezoid ligament. So, if the conoid ligament, this is your conoid ligament, okay? If the conoid ligament becomes taut, its attachment on the clavicle becomes an axis for the upward rotation of the clavicle occurring at the sternoclavicular joint. Okay, can you imagine? Again, this is your conoid ligament. Okay, it is a type of the coracoclavicular ligament. So the conoid ligament, if it tightens due to movements around this area, it will now enable the clavicle to rotate posteriorly. So here. So if this tightens, it will result to the clavicle rotating posteriorly. Therefore, posterior rotation of the clavicle at the sternoclavicular joint, okay, happens. Arthrokinematics of the sternoclavicular joint. When we say arthrokinematics, it is the movement happening between the articulating surfaces of the joints. Okay, so specifically the movement happening in this area. Before we discuss the arthrokinematics of the elevation of elevation, let's first review the articulating surfaces of the sternoclavicular joint. Okay, if you can remember, this is a saddle joint, meaning its articulating surface both has the convex and concave. Okay, each articulating surface of the bones involved in this joint both has the convex surface and concave surface. So specifically, if this is the cross-sectional view of the clavicle, so this one cross-sectional view, the longitudinal diameter of the clavicle is convex and the transverse diameter of the clavicle is concave. Okay, As to the sternum, opposite. Okay? So the longitudinal diameter of the sternum is concave, and transverse diameter of the sternum is convex. Okay? With that, motions happening in the frontal plane. Okay, motions happening in the frontal plane, that is elevation and depression, follows the opposite rule. Convex on concave rule. Okay, because this is the longitudinal um, articulating surface of the clavicle. That is open kinematic chain. Okay, if we are talking about open kinematic chain, it follows the convex over fixed concave rule, or the opposite rule. Now, if we are going to talk about movements happening in the transverse or horizontal plane, specifically protraction and retraction, open kinematic chain, so it is the clavicle that's moving, it follows the same rule. Okay, the concave segment moving over a fixed convex segment. Okay, with that, as to the elevation, as you can see, the orthokinematics of elevation, specifically open kinematic chain, so meaning it's the proximal segment that is moving on a fixed distal. Open kinematic chain, meaning the distal segment is moving on a fixed proximal segment. So orthokinematics, open kinematic chain of elevation is the convex articular surface of the clavicle rolls superiorly, so just following the shaft of the clavicle, because when you elevate or, or when clavicular elevation happens, the shaft also moves superiorly, right? Therefore, the roll will be superior. Then slides inferiorly following the opposite rule, because it is the convex part of the articulating surface of the clavicle that is moving against the concave articulating surface of the sternum. Okay, again, the convex articular surface of the clavicle rolls superiorly and slides inferiorly on the fixed concave articular surface of the sternum. Clear? As in the structures limiting elevation, so we have here your costoclavicular ligament and also the subclavian muscle. So as you can see, as the clavicle rolls superiorly, it will cause tightening of the costoclavicular ligament, which is located inferiorly, therefore limiting elevation of the clavicle. The arthrokinematics for depression still follows the opposite rule, because it is still the convex that is moving over a concave surface. So specifically, the arthrokinematics for depression open kinematic chain is the convex articulating surface of the clavicle rolls inferiorly, so still following the shaft of the clavicle, which moves inferiorly. So rolls inferiorly and slides superiorly over the fixed articulating surface of the sternum. As to the structures limiting the movement, we have your interclavicular ligament, the superior capsule, of course, and the first rib. Okay, as to the first rib, as you can see, if the clavicle depresses, the first rib is located there anatomically, so it cannot further depress anymore. Okay, that's why it limits depression. As to the interclavicular ligament, um, since its location is here, remember its function is to prevent upward displacement of the clavicle. So basically, that is the sliding of the clavicle superiorly in the sternoclavicular joint. So the interclavicular ligament, if there is depression of the clavicle, it will cause sliding of the clavicle's articulating surface superiorly. But you have the interclavicular ligaments there. Therefore, it will prevent excessive superior translation or superior gliding of the clavicle in the sternoclavicular joint. And of course, the superior capsule will prevent the excessive sliding of the clavicle superiorly during depression of the clavicle. Next, protraction and retraction. So protraction and retraction happens in the transverse plane. Therefore, it is the concave articulating surface of the clavicle that is moving over the fixed convex articulating surface of the sternum, if it's open kinematic chain, okay? So we are to follow now the same rule. So first, protraction. So this is your protraction. If you are to imagine the shaft of the clavicle is moving anteriorly. So we are to follow that for the roll, and therefore, since this follows the same rule, the direction of slide or glide of the clavicle will also be anterior. Okay, why anterior? As you can see, we have here a video. Okay, this is protraction. The shaft is moving anteriorly during protraction. Therefore, the roll, open kinematic chain, protraction, the roll will be anterior, and since it follows the same rule, then the glide or the slide happening on the clavicle is anterior also. Okay, so again, arthrokinematics of protraction, the concave, okay, transverse plane protraction is happening in the transverse planes. So we are to follow the concave surface of the clavicle if it's open kinematic chain. So the concave articular surface of the clavicle rolls anteriorly, just like the video a while ago, and slides anteriorly as well on the fixed convex articular surface of the sternum. Okay. As to the structures limiting the movement of protraction in the sternoclavicular joint, again we have the posterior sternoclavicular ligament, which we already discussed a while ago. For retraction, we are still to follow the similar rule as to protraction. Since during retraction, it is still the concave articular surface of the clavicle that is moving on a fixed convex articular surface of the sternum in an open kinematic chain. With that, during clavicular retraction, the articular surface or the concave articular surface of the sternal end of the clavicle rolls posteriorly and slides posteriorly. So we are applying the same rule on the fixed convex clavicular facet of the sternum. Okay, so here is a video again of retraction. As you can see, the shaft of the clavicle moves posteriorly, so that will be the direction of the roll. And since we are to follow the same rule, because it is the concave articulating surface of the clavicle that is moving in an open kinematic chain, the slide will also be the same with the direction of the roll. Okay, now as to the ligaments that limits the movement, we have the anterior sternoclavicular ligament, which was discussed already previously. For transverse rotation or posterior rotation or upward rotation, we just have to remember that the arthrokinematics for this movement is that the head of the clavicle spins about the articular disc. Okay, that's it. Before we identify the loose pack, close pack, and capsular pattern of the sternoclavicular joint, let's first briefly define each of these terms. Okay, so when we say loose pack position or resting position or open pack position, this is the position of minimal congruency between the articular surfaces and the joint capsule, with the ligaments being in the position of greatest laxity. Okay, so please remember the ligaments are in greatest laxity. Therefore, there is minimal congruency between the articular surfaces of the joint. With that, the joint the passive separation of the joint surfaces will be the greatest. Okay, since there is minimal congruency between the articular surface and the passive separation of the joint surfaces is greatest here, it allows or it provides proper joint lubrication and allows arthrokinematic movements in the joint. Okay. To add with that, your open pack position or resting position or loose pack position is the initial, most of the time the initial and also the most common position for treatment using joint play mobilization. Joint play mobilization is one of the manual techniques that we do as physical therapists to increase mobility on the joint, therefore increasing range of motion. Okay, for the closed pack position, it is the opposite of the open pack position or the loose pack position. When we say closed pack position, the two joint surfaces fit together precisely. So it is the position where there is maximum congruency between the articular surfaces of the joint. With that, the ligaments and capsule of the joint are also maximally tight. That's why it's very hard to move the joint during the closed pack position. And also very difficult or cannot be separated by destructive forces. So this is the position of maximum stability. As the physical therapy treatment, their closed pack position is used during treatment to stabilize the joint if the adjacent joint is being treated. Okay. Then lastly, we have the capsular pattern. The capsular pattern defines that if a pathological condition involves the entire joint capsule of a specific joint, it will present with a particular pattern of restriction. So please remember that particular pattern of restriction involving most of the passive motions of the joint. Okay, again, if there is affectation of the joint capsule of a joint, the manifestation of the patient will be, or there will be a pattern as to the restrictions of the mobility of the patient or of that joint. That is your capsular pattern. Meaning, if the capsular pattern of sternoclavicular joint is full elevation limited and pain at extreme ROM, if the problem in the sternoclavicular joint area is the joint capsule, patient will present with this limitation or with these symptoms. Okay, for the open pack position, it is arms resting by side, and for the closed pack position, arm maximally elevated. For the articular surface of the acromioclavicular joint, we have the lateral end or the acromial end of the clavicle and the clavicular facet of the acromion of the scapula. As you can see, the acromioclavicular joint is separated by an articular disc just like the sternoclavicular joint. An extensive dissection of 223 sets of cadaver or of AC joints reveals complete disc is only about 10% of the joints. Even if it's just 10% of the joints, this is not considered as a structural anomaly, but it is actually an indication of the degeneration that often affects the joint. As to the type of joint, it is gliding or plane joint. Why is it plane, ma'am? It's because of the flat surface of the articular surfaces of the joint. Okay? So they actually vary from flat to slightly convex or concave. But in general, we consider them as flat. That's why they are plane joint. Plane synovial diarthrodal joint. Okay, since they are since the articular surfaces of this joint is predominantly flat, the arthrokinematics of this one as to roll and slide is not described. Okay, please remember that because of the predominantly flat joint surfaces, the roll and slide arthrokinematics are not described for the acromioclavicular joint. So we will just be focusing on the kinematics of the acromioclavicular joint later on. For the ligaments, let's start with the acromioclavicular ligament. So from the name itself, the attachment of this ligament is the acromion of the scapula and the clavicle. Acromioclavicular ligament. If you will look at the anatomical location of the ligament, it really serves its function as to reinforce the joint capsule. Next, we have your coracoclavicular ligament. So from the coracoid process and to the clavicle. So this is your coracoclavicular ligament. Under the coracoclavicular ligament, we have two, your conoid ligament and your trapezoid ligament, which was mentioned already a while ago. So for the conoid ligament, it extends almost vertically, as you can see, vertically from the base of the coracoid process to the conoid tubercle of the clavicle, which was again mentioned already a while ago under the bone section of this presentation. Then for the trapezoid, it extends superior and laterally, so superior lateral direction from the superior surface of the coracoid process to the trapezoid line found in the lateral end of the clavicle. For the function of your coracoclavicular ligament, it provides an important extrinsic source of stability to the AC joint and helps in suspending the scapula and therefore the whole upper extremity from the clavicle. Because if you look at the area, okay, the coracoclavicular ligaments are the only ligament that actually connects the scapula and therefore the upper extremity to the clavicle. Okay. The movements under acromioclavicular joint are actually divided into two categories. So we have your primary movement and your secondary motions or your rotational adjustment motions. So let's proceed first with your primary movement. Under your primary movement, we have the upward rotation of the scapula and the downward rotation of the scapula. So, as to the plane of motion of upward and downward rotation, it is frontal plane or coronal plane, although most natural motions occur within the scapular plane. Okay, but for discussion purposes, frontal or coronal plane is also accepted. Then the axis of rotation is the z-axis or the anterior posterior axis. So this one. Okay, please don't be confused with the scapular plane that I have mentioned a while ago, because if you can remember, your scapula, right, is tilted posteriorly. So specifically on the scapular plane, right, is tilted posteriorly with reference to the frontal or coronal plane. Next, let's proceed with the secondary motions. Under secondary motions, we have your internal rotation, this one, and external rotation. So it's kind of similar to the internal rotation of the shoulder, right? So the movement of the internal rotation of the shoulder is towards this direction. So same with the scapula, it follows. Then again, external rotation. As to the plane of motion, it will be your transverse or your horizontal plane, and the axis of rotation is the x-axis. Sorry, the y-axis. Y-axis or the vertical axis. Then lastly, we have the anterior tilting and the posterior tilting. When we say anterior tilting, the superior part of the scapula is tilting forward, so that will be a reference. Therefore, the inferior part of the scapula will now tilt backwards. Okay, let's try to draw. If this is your scapula, this is anterior, this is posterior. Okay, so when we say anterior tilting of the scapula, the superior part will tilt anteriorly. Okay, then therefore the inferior part will tilt posteriorly. Please don't be confused. So if you illustrate anterior tilting, the scapula will be oriented this way. And for the posterior tilting, it will be oriented this way. Okay, anterior tilting, this one, posterior tilting, this one. This is lateral view. Lateral view. Anterior tilting, posterior tilting. Okay. As to the planes of motion, it is the sagittal plane, and therefore the axis of rotation is the x-axis. So this one. Ma'am, what do you mean by secondary motions or rotational adjustment motions? So these so-called rotational adjustment motions are needed to optimally align the scapula against the thorax, as well as adding the total amount of its motion. That's why it's not considered as primary movement, because the primary movement of the acromioclavicular joint is the upward and downward rotation. But the secondary motions or the rotational adjustments are needed, so meaning there should be adjustments within the acromioclavicular joint for it to perform its total amount of its motion. And again, these adjustments will be in the form of internal rotation, external rotation, anterior tilting, and posterior tilting of the acromioclavicular joint. Okay? So of the scapula in the acromioclavicular joint. Therefore, overall, we have 3 degrees of freedom for the acromioclavicular joint. Okay, for the acromioclavicular joint, again, we will not be describing the arthrokinematics or specifically the roll slide arthrokinematics of this joint, because the articular surfaces of the acromioclavicular joint is flat. Okay, that's why it's not applicable, but for this one, we are to focus on the kinematics or the motions happening in the articular surfaces of the acromioclavicular joint. Let's start with the primary movement. So we have your upward rotation of the scapula and downward rotation of the scapula at the acromioclavicular joint. So for the upward rotation of the scapula, we have a better visualization here, better illustration. So upward rotation of the scapula at the AC joint occurs as the scapula swings upwardly and outwardly relative to the lateral end of the clavicle. So this motion occurs as a natural component of abduction or flexion of the shoulder, meaning if you perform glenohumeral joint flexion or glenohumeral joint abduction, there will be upward rotation of the scapula at the acromioclavicular joint. Okay? For the downward rotation, so downward rotation at the AC joint returns the scapula back towards the anatomic position. So just the opposite. Okay? And therefore, this motion is mechanically associated with shoulder adduction and extension. So when you perform glenohumeral adduction and extension, there will be downward rotation of the scapula at the acromioclavicular joint. Let's proceed with the secondary motions or the rotational adjustment motions of the AC joint. Okay, first we have your horizontal plane adjustments, specifically the internal rotation and external rotation of the scapula. Ma'am, why are they called horizontal plane adjustments? Because these are adjustments or adjustment motions that happens in the horizontal plane or the transverse plane, which we have discussed a while ago. Okay, for this one, this is evident by the medial border of the scapula pivoting away and toward the posterior surface of the thorax. So don't be confused, okay? If the scapula moves, if the medial border of the scapula moves posteriorly, that is internal rotation, then anteriorly, that is external rotation. Ma'am, it's confusing. It's kind of opposite to what I know. For you to be able to better visualize this, look at the glenoid cavity around this area. Okay? So internal and external rotation is defined by the direction of rotation of the glenoid fossa around this area. So when you say internal rotation, the glenoid fossa is going internally. Okay, like the shoulder going in internal rotation. Then when you say external rotation of the scapula at the acromioclavicular joint, the glenoid fossa is going externally. Okay, outside, away from the body. So that is like the shoulder doing external rotation. Okay? before we proceed with this one, I forgot to mention, so internal rotation of the scapula occurs during protraction, scapulothoracic protraction, and external rotation of the scapula at the acromioclavicular joint occurs during retraction of the scapulothoracic joint. Okay, that is for the previous slide. Sorry, I forgot to mention. Now let's proceed with the anterior tilting and posterior tilting of the scapula in the acromioclavicular joint. So we have here your sagittal plane adjustments, specifically the anterior tilting and posterior tilting of the scapula. Ma'am, why are they called sagittal adjustments, sagittal plane adjustments? Because, again, the movement occurs in the sagittal plane. So this is the lateral view of your scapula. This is your glenoid fossa connecting to the humeral head of the humerus in order to form the glenohumeral joint. Okay? So the humerus is removed to show the glenoid fossa. When we say anterior tipping or anterior tilting, look at the glenoid fossa as basis. If the glenoid fossa tilts anteriorly, therefore, the inferior angle of the scapula will tilt posteriorly. That is anterior tilting. Again, our reference will be the glenoid fossa, just like the internal rotation and external rotation of the scapula at the acromioclavicular joint. Now, for the posterior tilting, glenoid fossa tilts posteriorly, while the inferior angle of the scapula tilts anteriorly. Okay, so that is your posterior tilting or posterior tipping. They are the same of the scapula at the acromioclavicular joint. So if you are to use this reference to visualize IR and ER, internal rotation will be moving towards here and internally. Then external rotation is towards here, then away or externally. Okay, don't be confused. This is the anterior and this is the posterior side. Okay. Loose pack position or resting position or open pack position of the AC joint is arm resting by side, just like your SC joint. Closed pack position is 90 degrees abduction, and capsular pattern is full elevation limited and pain at extreme ROM or range of motion, just like your SC joint. Our third joint is the glenohumeral joint. For the articulating surface or articular surface of the glenohumeral joint, first we have the head of the humerus, so this one, and the glenoid cavity or glenoid fossa of the scapula. Okay, as you can see, this is a ball, which is the humeral head, and socket, which is the glenoid cavity or glenoid fossa. So this is a ball and socket synovial diarthrodial joint. For the periarticular connective tissues and supporting structures of the glenohumeral joint, let's start first with the joint capsule or the fibrous capsule of the glenohumeral joint. So the GH joint is surrounded by a fibrous capsule that isolates the joint cavity from most of its surrounding tissues. So the capsule attaches from the rim of the glenoid fossa medially and extends to the level of the anatomical neck laterally. So this is your anatomical neck, right? Aside from the fibrous capsule, we have your synovial membrane. So your synovial membrane lines the inner wall of your fibrous capsule. Okay, an extension of the synovial membrane lines the intracapsular portion of the tendon of the long head biceps brachii. Okay, so meaning, ma'am, there is a portion of the long head of biceps brachii that is intracapsular. Intracapsular meaning within the fibrous capsule, within the joint capsule. Yes, okay. Why? Because its origin is located in the supraglenoid tubercle, which is inside the fibrous capsule. Okay, so this synovial membrane here, as you can see, it extends and lines the intracapsular. This is the intracapsular portion of the long head of biceps brachii, the one in white. Okay. So it continues surrounding the biceps tendon as it exits the joint capsule and passes to the bicipital groove, okay, or the groove between the the greater and lesser tubercle, okay. So the head of the humerus and the glenoid fossa is lined with the articular cartilage. Okay, please remember that. Another supporting structure within the glenohumeral joint is the articular cartilage of the humeral head and the articular cartilage of the glenoid fossa. So actually, your joint capsule is twice the size of the humeral head. Okay, so the joint capsule is twice the size of the humeral head. Okay, as the volume. Now, is that good? Yes, actually, it is good. So the loose-fitting and expandable capsule allows now the extensive mobility in the glenohumeral joint, which is actually needed by us because as we review, the function of the upper extremity, right? It involves large movements. The shoulder joint is needed to reach for objects. Okay, so the the increase in volume of the joint capsule actually allows the glenohumeral joint to have an extensive mobility. Before we proceed with the ligaments surrounding the glenohumeral joint, let's first discuss the two openings present in the synovial cavity of the joint. Okay, so we have the foramen of Whitebread or Whitebread, depends on the pronunciation. They have different pronunciation for this one, and the foramen of Rovere. Okay, so for the foramen of Whitebread, it is located, foramen, again, it's opening. Okay, so basically, it is an opening located between the superior glenohumeral ligament and the middle glenohumeral ligament. For the foramen of Rovere, it is the opening located in the synovial cavity of the joint, specifically between the middle glenohumeral ligament and inferior glenohumeral ligament. Now, why is it important for us to be familiar with this foramina? Foramina is the plural of foramen. Okay? It's actually associated with your shoulder dislocation. Trivia, the most common direction of shoulder dislocation is anterior. Okay, so again, the most common direction of shoulder dislocation is anterior. We have different factors that may explain on that phenomenon. Okay, and one will be the presence of the foramina in the anterior part of the joint cavity. Okay, so the presence of the foramen of Whitebread and foramen of Rovere can be a reason on why the most common direction of shoulder dislocation is anteriorly. Of course, if there is an opening in this area, it weakens now the anterior part of the joint, okay, or of the capsule. Is that clear? So this is a cross-sectional view. As you can see, there is an opening. This is the superior GH ligament, middle GH ligament, and inferior GH ligament. So we have here the opening. Okay, so another cross-sectional view showing you the opening and the different ligaments. Okay, so this is MRI cross-sectional view again. This is anterior, this is posterior. So this is your superior GH ligament here. This is your coracoid process. So the location of these foramen is inferior to the coracoid process. So this is the one in the black arrow is the superior GH ligament. The white area with X, that is the opening, the foramen of Whitebread. Then the gray arrow is the middle GH ligament. Then another opening for the foramen of Rovere, and the one in the white arrow is the inferior glenohumeral ligament. So specifically, the foramen of Whitebread is the area where the head of the humerus is more prone to dislocation. Okay, please remember that. For the ligaments, let's first discuss the glenohumeral ligaments. So we have three. Your superior glenohumeral ligament from the supraglenoid tubercle of the scapula to the anatomical neck of the humerus. Your middle glenohumeral ligament from the glenoid fossa to the anatomical neck of the humerus, and your inferior glenohumeral ligament from the glenoid fossa to the anatomical neck. Okay? So for the superior glenohumeral ligament, by the way, the reference for this part of the discussion will be your Newman. Okay, so let's follow Newman for consistency among the sections. Okay, so again, your superior glenohumeral ligament is taught in ER and restrains inferior and anterior translation of the humeral head. So please remember the superior glenohumeral ligament around this area. So this one and below the coracohumeral ligament. Again, it is taught in ER. Taught is like tight, okay? Taught in ER and it restrains inferior and anterior translation of the humeral head. You can actually connect the anterior translation of the humeral head and tightening of the superior glenohumeral ligament during ER. Remember, when you do external rotation of the shoulder, okay, open kinematic chain, the roll is posterior but the sliding of the humeral head is anteriorly. Okay, so when it slides anteriorly, now you have your superior glenohumeral ligament restricting or restraining excessive anterior translation of the humeral head. That's why it is taught during external rotation. Okay? Your middle glenohumeral ligament is also taught during ER, and it restrains still anterior translation of the humeral head. As you can see, it's located here. Okay? So it restrains anterior translation of the humeral head, especially in the 45 to 60 degrees of abduction. Please remember the difference between the two. Okay? Next, we have your inferior glenohumeral ligament. So your inferior glenohumeral ligament actually has other or subcategories. Okay? So we have the anterior band, the posterior band, and the axillary pouch. Again, we have the anterior band, posterior band, and axillary pouch. For better discussion of the components of the inferior glenohumeral ligament, let's use this illustration. So this is a cross-sectional view of the glenohumeral joint from the lateral side, okay, or from the lateral view. So again, this is your anterior band, your posterior band, and the axillary pouch, okay, anterior band, posterior band, and the axillary pouch, okay, like a pouch. So let's first discuss the axillary pouch. So the axillary pouch become most taught in about 90 degrees of glenohumeral joint abduction. Okay, again, your axillary pouch is taught at 90 degrees of shoulder abduction. At the same time, since it's like a pouch, so it acts like a sling. Okay, so if the axillary pouch is taut, it supports now the suspended humeral head around this area and provides a cradling effect because it is like a pouch that now receives inferior and anterior-posterior translations. Okay, so in short, the axillary pouch again is taut at 90 degrees of abduction and receives inferior, anterior, and posterior translation of the humeral head. Next, we have your anterior band of the inferior glenohumeral ligament. Okay, so let's use another picture for this one. Let's go back with this illustration for the anterior and posterior band of the inferior glenohumeral ligament. Okay, so if the axillary pouch is taut at 90 degrees abduction and receives inferior, anterior, and posterior translation of the humeral head, your anterior band, which is located here, of the inferior glenohumeral ligament and posterior band. So it's located posteriorly, but it is around this area of the glenohumeral ligament is taught at extreme ranges of external and internal rotation at 90 degrees shoulder abduction. Okay? So for the anterior band of the inferior glenohumeral ligament, it is taught or it becomes taught at 90 degrees shoulder abduction with extreme or full external rotation. Okay, can you imagine why external rotation? Because when there is external rotation, the movement or the sliding of the humeral head is anteriorly and the roll is posteriorly. So can you imagine that? So if there is ER, okay, the humerus will move away and posteriorly. So now the anterior band will be taut, okay, specifically at 90 degrees abduction. So a 90 degrees abduction with full external rotation, it is the anterior band that is taut. Now on the other hand, if it's 90 degrees abduction with internal rotation, so internal rotation will be like this. Okay. Of course, it is the ligament that's located posteriorly that will be taut. Okay. So the posterior band of the inferior glenohumeral ligament is taut at 90 degrees of abduction and full or extreme internal rotation. Okay. Please don't confuse yourselves with these functions. Okay. Don't forget the 90 degrees as well. If it's just 90 degrees of abduction, it's more of the axillary pouch. Okay. Additional, for the anterior band of the inferior glenohumeral ligament is it also prevents excessive anterior translation of the humeral head. Okay, or anterior sliding of the humeral head. Of course, if we are to draw that, this is the superior view, this is your humeral head, this is the glenoid fossa, okay? Superior view, guys. Then, this is the anterior band, okay? Of course, your anterior band will prevent anterior translation of the humeral head, okay? And actually, this is a very important information because your anterior band is actually the strongest and the thickest part of the entire shoulder capsule. Okay? Again, the anterior band is the strongest and thickest part of the entire capsule. And since it restrains anterior translation of the humeral head, not only, well, it's most taught at 90 degrees abduction and extreme ER, but it actually is able to restrain anterior translation of the humeral head in both abducted and neutral position. Okay? That's why it is important. Okay? Remember, the most common direction of dislocation in the shoulder is anteriorly, right? So, now your anterior band is very important to prevent that. To apply it in a clinical scenario, forceful and dynamic activities involving abduction and external rotation, oh, that those movements are the combination of movements that promotes or that stretches the anterior band of the inferior glenohumeral ligament. Remember, the anterior band of the inferior glenohumeral ligament is taut at 90 degrees abduction and extreme ER. So if there are forceful and dynamic activities involving abduction and external rotation of the glenohumeral ligament, that will actually stress the anterior band of the inferior capsule, including the anterior band of the inferior glenohumeral ligament. Okay? So over many repetitions of this action, it may now cause stress and microtrauma and tear on the anterior band of the inferior glenohumeral ligament. Okay? Now, with that, it will weaken the ligament, and therefore the patient, for example, may now be predisposed with anterior dislocation. So one example is the coffin face or pictures, specifically the cocking phase of throwing of ball. For your information, throwing a ball involves several phases. So one phase of throwing a ball is the cocking phase. Okay? During the cocking phase, so this is the cocking phase, the shoulder is positioned in abduction and extreme external rotation. So this is actually the combination of movements that predispose or give so much stress in our anterior band of the inferior glenohumeral ligament. So usually players, pitchers, or those players involving this type of motion, those athletes who usually do this type of motion are prone to stressing that ligament. And now, if there is constant stress on that ligament, it will result to microtrauma. Then eventually, it may also result to tear. And of course, microtrauma tear will result to weakening of the anterior band of the inferior glenohumeral ligament, and eventually, it will now predispose the patient to anterior dislocation of the shoulder. Next, we have your coracohumeral ligament, which blends with the superior capsule and the supraspinatus tendon, although it is not visible here. So your coracohumeral ligament is relatively taut in the anatomical position. Okay, so from this position, the coracohumeral ligament provides restraints to inferior translation and external rotation of the humeral head. So please remember, it provides restraints to inferior translation. Why inferior translation? Because it is part or it blends with the superior capsule, therefore it will restrain inferior translation of the humeral head and also external rotation. And lastly, we have the transverse humeral ligament. Okay, so your transverse humeral ligament extends between the two tubercles of the humerus, your lesser tubercle and your greater tubercle. Okay, the function of your transverse ligament is to hold the tendon. What tendon? Tendon of the long head of biceps brachii as it passes in the intertubercular or bicipital groove. Is that important? Yes, of course. Okay. Why? Because we don't want our biceps tendon to be moving around this area every time the biceps muscle contracts. Okay. With the transverse ligament, it holds the biceps tendon in that place. Therefore, it's just there every time the biceps muscle contracts. Okay. For the osteokinematics, we have 3 degrees of freedom for the glenohumeral joint. Why 3? Because movements in the GH joint happen in the 3 planes of motion. So specifically, flexion extension happens in the sagittal plane, and the axis of rotation is the x-axis or the medial lateral axis. Abduction and adduction happens in the frontal or coronal plane, with the axis of rotation, the z-axis or the anterior posterior axis. And lastly, your internal rotation and external rotation happens in the transverse or horizontal plane, with the axis of rotation as the y-axis or vertical axis. Okay. For the Oftentimes, a fourth motion is defined at the glenohumeral joint, which is your horizontal adduction and abduction. Okay, also called as your horizontal flexion for the horizontal adduction and horizontal abduction for the horizontal extension. Okay, so the motion occurs from a starting position of 90 degrees abduction. So at first, position the extremity at 90 degrees. So if you can imagine, this is the person, okay, this is the neck, 90 degrees of abduction, okay. This is anterior view. So this is the other extremity in the anatomical position. So 90 degrees abduction. Okay. If the humerus moves anteriorly, that is horizontal abduction. If the humerus moves posteriorly, that is horizontal abduction. This is very easy, okay? For the arthrokinematics of the GH joint is very easy. Just remember the articular surfaces of the glenohumeral joint. We have a ball and socket. Ball, so ball is convex. Socket is concave. Okay, so if it's open kinematic chain, this distal segment moving on a fixed proximal segment, then we will follow the opposite rule. And when it's closed kinematic chain, the concave segment moving on the fixed convex, then we will follow the same rule. Okay. Now, for the abduction adductions, let's go first with the abduction. During abduction, the convex head of the humerus roll superiorly, so just follow the shafts of the humerus which moves superiorly as well, and slides inferiorly, so opposite rule because it's the convex that moved and not the concave. Okay, so abduction, open kinematic chain, so it's the humerus that's moving on the fixed glenoid fossa. Convex head of the humerus rolls superiorly and slides inferiorly against the concave glenoid fossa of the scapula. Now, for the adduction, open kinematic chain, just reverse it. Okay, so the convex head of the humerus rolls inferiorly, so inferiorly, okay, and slides superiorly on a concave or on the fixed concave glenoid fossa of the scapula. Okay. Now, how about for closed kinematic chain? For closed kinematic chain, it is the proximal segment that is moving. Therefore, it is the concave segment that is moving. So, for abduction, closed kinematic chain, So, the concave glenoid fossa rolls superiorly. Let's just follow the same rule, okay? The roll will not change. If it's closed, whether it's closed kinematic chain or open kinematic chain, the roll will not change. So the concave glenoid fossa rolls superiorly and slides superiorly. So same rule because it's the concave that moves on the convex. Okay, against the fixed convex head of the humerus. For adduction, just reverse it. The concave glenoid fossa rolls, so copy the roll inferiorly. Okay, inferiorly. Let's try to draw. Adduction is towards this. Okay, adduction. Closed kinematic chain. So again, the concave glenoid fossa rolls inferiorly. Again, just follow the shaft of the humerus. And also slides inferiorly. Same rule applies because it's the concave glenoid fossa that's moving. So concave glenoid fossa of the scapula rolls and slides inferiorly against the convex head of the humerus. For the external and internal rotation, this is easy. As to the roll, guys, you just follow the shaft of the distal segment. So in this case, just follow the direction of movement of the shaft of the humerus. Okay? When you do external rotation, the roll is towards posterior. Okay? Towards posterior. And since it is the convex that's moving on the fixed concave, again, this is open kinematic chain first. Okay? The glide or the slide will be opposite in direction. So, open kinematic chain, arthrokinematics of external rotation, the convex head of the humerus rolls posteriorly and slides anteriorly on the fixed concave glenoid fossa of the scapula. For the internal rotation, just reverse. Okay, so the convex head of the humerus rolls anteriorly, following the shaft of the humerus, which also moves anteriorly. So rolls anteriorly and slides posteriorly against the concave glenoid fossa of the scapula. Now, for the closed kinematic chain, arthrokinematics of external rotation, follow the same rule because it's the concave glenoid fossa that is moving over the fixed convex humeral head. Okay, so specifically for external rotation, again, same as to the role on the open kinematic chain. So external rotation, closed kinematic chain, concave glenoid fossa of scapula rolls posteriorly and slides posteriorly as well against the convex head of the humerus. Then for the internal rotation, concave glenoid fossa of the scapula rolls and slides anteriorly against the convex head of the humerus. For the flexion and extension, this is actually different. Okay, there is no rolling. Instead, we have spinning. Okay, so specifically for flexion, this is anterior view, anterior part, posterior part. So this is lateral view. Okay, so during flexion, there is spinning only. Okay, so the convex head of the humerus spins. And during extreme flexion, it slides anteriorly against the concave glenoid fossa. Again, the convex head of the humerus spins and during extreme flexion slides anteriorly against the concave glenoid fossa. Why does it slides anteriorly? It's the result of the ligaments tightening during extreme flexion. Okay, that is open kinematic chain. So for the closed kinematic chain, just reverse it. Spinning, still spinning, but posterior slide at extreme flexion. Okay, for extension, the convex head of the humerus spins, and now this time it slides posteriorly during extreme extension or during hyperextension against the concave glenoid fossa of the scapula. Why is it sliding posteriorly during hyperextension or during extreme extension? It's just the result as well of the ligaments tightening. Okay, that is open kinematic chain. Again, the convex head of the humerus spins, and during extreme extension or hyperextension, it slides posteriorly against the concave glenoid fossa of the scapula. For the closed kinematic chain, just reverse. Okay, so the concave glenoid fossa spins and slides anteriorly during extreme extension, hyperextension against the convex head of the humerus. Open back position is 55 to 70 degrees abduction, 30 degrees horizontal abduction, and neutral rotation. Closed back position is maximum abduction and the external rotation, and capsular pattern is erabir or external rotation. Greatest limitation in external rotation, then abduction, then internal rotation, erabir. Let's now proceed with the false joints. First, we have the scapulothoracic joint. Articulating surface is point of contact between the anterior surface of the scapula and the posterior lateral wall of the thorax. Okay, so this is a false joint because the two surfaces do not make direct contact. Rather, they are separated by layers of muscles such as your subscapularis, latus anterior, and your erector spinae. So the joints responsible for the movements of your scapulothoracic joint are the sternoclavicular joint and the acromioclavicular joint. Okay, please take note of that. For the scapulothoracic joint to produce movement, so for movement to happen in this area, there should be movement in the SC joint and the AC joint. Okay. This is just another illustration to show how the sternoclavicular joint and the acromioclavicular joint results to movement of the scapula in the scapulothoracic joint. Again, movement of the SC joint and movement in the AC joint will now cause movement of scapula in the scapulothoracic joint. So let's now discuss the interaction between the SC joint and the AC joint to cause movement in the scapulothoracic joint. So specifically for elevation of the scapula at the scapulothoracic joint, there should be elevation of the clavicle in the sternoclavicular joint and downward rotation of the scapula in the acromioclavicular joint. Okay, that combination of movements will now cause elevation of the scapula at the scapulothoracic joint. Now for the depression, just reverse it. So depression of the scapula in the scapulothoracic joint is from depression of the clavicle. So here, depression of depression of the clavicle in the sternoclavicular joint and upward rotation of the scapula in the acromioclavicular joint. This is posterior view, okay? Please don't be confused. For protraction and retraction, still it has to have movements in the SC joint and the AC joint. Okay? For the protraction, so for protraction of the scapula to happen in the scapulothoracic joint, there should be protraction of the clavicle in the sternoclavicular joint and slight internal rotation of the scapula in the AC joint. Okay? Now, for retraction, just reverse it. So, for retraction of the scapula to happen in the scapulothoracic joint, there should be retraction of the clavicle in the sternoclavicular joint and slight external rotation of the scapula in the AC joint. Lastly, for upward, and downward rotation of the scapula in the scapulothoracic joint. First, let's proceed with the upward rotation. So for the upward rotation of the scapula in the scapulothoracic joint, there should be elevation of the clavicle in the sternoclavicular joint and upward rotation of the scapula in the acromioclavicular joint. Now, for the downward rotation of the scapula in the scapulothoracic joint, just reverse it. There should be depression of the clavicle in the sternoclavicular joint and downward rotation of the scapula in the acromioclavicular joint. The next false joint in the shoulder complex is your suprahumeral joint or your subacromial space. Suprahumeral, above the humerus. Subacromial, below the acromion process. So specifically, your suprahumeral joint or your subacromial space is located between the coracoacromial arc, this is your coracoacromial arc, and the humeral head. Okay, around this area. Structures forming the joint will be the coracoacromial ligament. Your coracoacromial ligament is attached between the anterior margin of the acromion. This is the acromion process. So, anterior margin of the acromion and the lateral border of the coracoid process. Okay, so structures forming the joint of the suprahumeral joint is one, the coracoacromial ligament, and the next is the acromion process of the scapula. As to the contents, it contains four structures. First, we have your subacromial bursa. This is your subacromial bursa located below the acromial, subacromial bursa. We have the tendon of the supraspinatus muscle, the long head of biceps, tendon of the long head of biceps, and part of the superior capsule. Okay. For the clinical significance, so one clinical significance of this structure is related to the subacromial impingement syndrome, which will be your assignment. So you have to study about the subacromial impingement syndrome because that is a common condition encountered by physical therapists in the clinic. So please study about that because we will be discussing that during the synchronous session. Okay. The last joint for the shoulder complex is the bicipital groove, which is also a false joint. So it is the groove between the lesser tubercle and greater tubercle of the humerus. Bicipital groove or intertubercular groove. Structures forming the joint will be first the tendon of the long head of biceps brachii and of course the bicipital groove. As to the ligaments forming the joint, we have your coracohumeral ligament. So it is from the coracoid process to the humerus, okay, coracohumeral ligament, and the transverse ligament, which were discussed already previously in the presentation. Shoulder bursae, okay? So actually we have 8 bursae within the shoulder area, and some of them actually extend from the synovial lining of the capsule or are continuous with each other. However, for this lesson, we are only to discuss the 2 bursae. We have your subacromial bursa and your subdeltoid bursa specifically, okay? What is the function first of your bursa? Why are they important? So your bursa is important because it reduces friction between structures, okay? As you know, the tissue surrounding the joint moves. That's why the joint moves, okay? Because the structure surrounding the joint moves. Now, we have your bursa, which is sometimes located in between of these structures to prevent friction every time a specific structure moves, okay? So let's discuss it more comprehensively. This is your subacromial bursa. So the location of your subacromial bursa, subacromial. So it is between the acromion process and the supraspinatus. So it lies within the subacromial space, above the supraspinatus muscle and below the acromion process. Subacromial, below the acromion process. For the function, since it's located between the supraspinatus muscle and tendon and the acromion process, it now protects the vulnerable tissues of the supraspinatus muscle and tendon from the rigid undersurface of the acromion every time it contracts or every time it moves. Okay? Next, for the clinical significance, one clinical significance of this one will be correlated to your subacromial impingement syndrome. So you have to study for that as well. Okay? Our next bursa is just a lateral extension of the first bursa that we have discussed, okay? So the subdeltoid bursa is just a lateral extension of the subacromial bursa, as you can see. But this time, as to the location, it is actually below sub, so below the deltoid, because your deltoid is actually located here, okay? With its location, we can now conclude that the function of the bursa is to prevent or to limit frictional forces between the deltoid and the underlying supraspinatus tendon and humeral head. Okay? Then, function of the subdeltoid bursa is to limit frictional forces between the deltoid and the underlying supraspinatus tendon and humeral head. So let's watch this video for us to better understand the importance of your subacromial and subdeltoid bursae. So as you can see, every time the supraspinatus contracts, okay, it moves superiorly and actually decreases the subacromial space. Now, is that good? Actually, no, it's not good. Because if the supraspinatus moves superiorly every time it contracts or every time shoulder abduction happens, it is now getting closer to the rigid acromion process. But since we have your subacromial bursa around this area and subdeltoid bursa around this area, because we have your deltoid here, okay, even when the supraspinatus muscle contracts and translates superiorly, there will be reduced friction or it will not be exposed to so much friction between the acromion process and the deltoid here because of the presence of the bursa. Okay? Scapulohumeral rhythm. According to this, after 30 degrees of abduction, there is 2:1 ratio between the glenohumeral joint and the scapulothoracic joint, such that for every 15 degrees of abduction, 10 degrees occur in the GH joint, that is the 2, in the 2:1 ratio, and 5 degrees occur in the SC joint, that is the 1 in the 2:1 ratio. Okay? Meaning, for you to perform abduction, there is movement coming from the glenohumeral joint, and there is also movement coming from the scapulothoracic joint. Specifically, there is 2:1 ratio between the glenohumeral joint and the scapulothoracic joint. Let's discuss it further. So, in the healthy shoulder, a natural kinematic rhythm or timing exists between glenohumeral abduction and scapulothoracic upward rotation during shoulder abduction. Okay, so please remember, during shoulder abduction of the glenohumeral joint happens and upward rotation of the scapula in the scapulothoracic joint happens. The early phase of abduction, or the setting phase, that is around 0 to 30 degrees, is actually variable in individuals. However, after 30 degrees of abduction, there is 2:1 ratio between the glenohumeral joint and the scapulothoracic joint. Please remember this one, 2:1 ratio. Okay, so let's divide the shoulder abduction into two phases. We have your early phase of abduction, that is specifically 0 to 90 degrees, and the late phase of abduction, that is 90 to 180 degrees. Why 180? Because the full range of motion of shoulder abduction is 0 to 180. So if you are to divide it into early phase and late phase, just divide 180. Okay, 0 to 90 and 90 to 180. So the scapulothoracic rhythm for the early phase of abduction, for example, the 90 degrees. Okay, for you to reach 90 degrees of abduction, there should be 60 degrees of glenohumeral abduction plus 30 degrees of scapulothoracic upward rotation, following the 2:1 ratio. Okay, then as you can remember, the scapulothoracic motion is a result of movement in the sternoclavicular joint and acromioclavicular joint. So, meaning, for scapulothoracic movements to happen, there should be combination of movement in the sternoclavicular joint and acromioclavicular joint. Okay, so specifically, for the early phase of abductions, on the scapulothoracic upward rotation, so the 20 to 25 degrees, so there should be, remember, 30 degrees of upward rotation, okay? 30 degrees of upward rotation of the scapula in the scapulothoracic joint. So, it will be divided now. The 20 to 25 degrees will be coming from the clavicular elevation at the level of the sternoclavicular joint, and the rest, the 5 to 10 upward rotation of the scapula, will happen in the acromioclavicular joint. Okay? Now, if you add them together, it will result to the 30 degrees of upward rotation in the scapulothoracic joint. For the late phase of abduction, so that is now up to 180. Okay? So, for you to be able to perform 180 degrees of abduction, there should be 120 degrees glenohumeral abduction and 60 degrees of scapulothoracic upward rotation. For the 60 degrees of scapulothoracic upward rotation to happen, okay, there is additional 5 degrees of clavicular elevation from this initial 20 to 25 degrees of clavicular elevation coming from the early phase that happened between the 0 to 90 degrees of abduction. And there is also an additional 20 to 25 degrees of upward rotation of the scapula at the acromioclavicular joint, in addition to the 5 to 10 degrees upward rotation of the scapula at the AC joint that happened already initially during the early phase 0 to 90 degrees of abduction. So that is your scapulohumeral rhythm. So basically, for shoulder abduction to happen, there should be movement in the glenohumeral joint, in the scapulothoracic joint, and since there is movement in the scapulothoracic joint, there should also be movement in the acromioclavicular joint and sternoclavicular joint. So this is just a video to show you what happens during abduction and specifically the scapulohumeral rhythm. Okay, as you can see, abduction of the shoulder involves abduction of the glenohumeral joint, upward rotation of the scapula at the scapulothoracic joint, upward rotation of the scapula in the AC joint, and elevation of the clavicle in the sternoclavicular joint. One last time. In addition to what we have discussed a while ago, please look at the clavicle. Aside from elevation, there is also posterior rotation. This is posterior view because this is the spine of the scapula which is located posteriorly. So as you can see, the clavicle also rotates posteriorly in the sternoclavicular joint. So this is the posterior rotation of the clavicle. Okay, and when it goes back to the resting position, it anteriorly rotates. Okay, if you can remember the movements in the sternoclavicular joint, we don't really consider the anterior rotation because it just happens after the posterior rotation of the clavicle when the clavicle has returned back to its resting position. Okay, please remember that there is also posterior rotation of the clavicle in the sternoclavicular joint during shoulder abduction. Muscles of the shoulder complex. For this part, we will be focusing on the synergies of scapular motions and glenohumeral joint motions, meaning we will be discussing the interaction between the muscles of the shoulder complex and how they produce the following scapular motions and glenohumeral joint motions. Okay? But as to the oina, origin, insertion, nerve supply and action, it will be your assignment to read, memorize, and analyze those things. Let's discuss the different synergies of the scapular motions. So for retraction of the scapula to happen at the scapulothoracic joint, there should be contraction of these three muscles. Your retractors, synergies for retraction, the middle trapezius, the rhomboids, and the lower trapezius. As you can see, when they contract, they produce force with different directions. However, combination of these different forces with different direction will now produce a single force that will result to retraction of the scapula. Okay, that's why they are called synergies because they work together in order to produce retraction in the scapulothoracic joint. Okay. For the protractors of the scapula at the scapulothoracic joint, we have your serratus anterior or your boxer's muscle. So please watch this video. Okay, so that is how your serratus anterior protracts your scapula. For the elevators of the scapula at the scapulothoracic joint, we have your upper trapezius. For the picture, it's located here, but if we are pertaining to the elevation, for example, of the right scapula, it's the right upper trapezius, okay? So the right upper trapezius, let's try to draw it. Okay, so here, attaching to the lateral end of the clavicle. So your upper trapezius, your levator, scapulae, this one, okay, and to a lesser extent, your rhomboids minor and your rhomboids major. So the force of contraction of these muscles will now result to elevation of the scapula at the scapulothoracic joint. So functionally, These muscles support the posture of the shoulder girdle and the upper extremity. Although it's variable to people, but the ideal posture of the shoulder girdle is actually for the scapula to be slightly elevated. So please remember that, slightly elevated and retracted. And your upper trapezius, which attaches to the lateral end of the clavicle, provides an excellent leverage around the sternoclavicular joint for maintenance of the ideal posture, because as you can see, since it is attached on the clavicle and the clavicle is connected with the scapula, it will now help in maintaining the ideal posture of the scapula in the scapulothoracic joint to be elevated and slightly elevated and retracted. Is that important? Yes, it is important. Okay, so for you to better understand why it is important, let's try to apply it in clinical scenarios. So if there is a pathology that is causing weakness on these muscles, so for example, affectation of the cranial nerve 11, which innervates your upper trapezius, or lower motor neuron lesions that causes weaknesses on these muscles, okay, meaning it will result now for the gravity, which is always going down. Remember your gravity, right, towards the core of the earth. So it's going down. If there will be weakness of these muscles, which maintains the ideal posture of the shoulder girdle, specifically slightly elevated and retracted scapula, if the gravity is now the dominant force on this area, it will be the one determining the posture of the scapula. So if the gravity is going down, it will now result for the scapulothoracic joint to be positioned in depression, protracted, and also excessively downwardly rotated. Okay, very different on the ideal posture. So now, because of that impaired posture, it may cause different stresses on the other structures located within the shoulder region. So, for example, over time, if there is depression of the scapula at the scapulothoracic joint and depression of the clavicle because of the gravity being the dominant force on the shoulder complex, gravity, okay, so it will now cause depression on the clavicle. It may result to superior dislocation of the SC joint. Okay, superior dislocation of the SC joint. Let's write it. Okay. How or why? As you can see, if the dominant force will be the gravity, which is going down, it will result for the clavicle, the lateral end of the clavicle, to go down. The medial end will not go down because of the presence of the underlying first rib here. Remember, you have your first rib under the clavicle, specifically on the medial end of the clavicle. So, because of the gravity going down in this area, the first rib will now serve as a fulcrum. So what will happen? It's like a seesaw. Okay, this is going down the lateral end and this one will go up. And that will cause dislocation on the sternoclavicular joint, specifically in the superior or upward rotation, like a seesaw. Okay, it's like this one. This is your first rib, lateral end of the clavicle, that is going down because of the gravity being the dominant force already due to weakness of the muscles maintaining the ideal posture in the shoulder complex, and the superior dislocation of the sternoclavicular joint. Now, the depressed shaft of the clavicle here will compress the structures under it. So the structures that are passing in this area. Is that important? Yes, it is important because the structures that passes under the clavicle are your subclavian vessels, so your arteries and veins that are responsible for giving blood supply to your upper extremity, and also part of your brachial plexus, which innervates your muscles of the upper extremity. So if If the clavicle now compresses these structures, it will cause problem in the upper extremity because you are removing or you are damaging the vessels responsible for giving blood in the structures of the upper extremity, or you are damaging, compressing the nerves responsible for innervating the upper extremity. So another consequence of long-term paralysis of the upper trapezius, so let's just draw the upper trapezius here. Okay, remember your upper trapezius, it helps in elevating the scapula and retracting the scapula. So one consequence of long-term paralysis of the upper trapezius is inferior dislocation or subluxation of the glenohumeral joint. If you can recall from your readings, the orientation of your glenoid fossa is actually slightly superior and medial, right? So it is oriented in a superior and medial direction. So I'll try to draw it. So if this is, for example, your glenoid fossa, it is oriented that way. And this actually promotes stability within the glenohumeral joint. This is a contributor for the static stability of your glenohumeral joint. So let's try to draw it. I'm not good at drawing, but example, this is your scapula. Okay, so it is the glenoid fossa is oriented in a superior direction in order to receive the humeral head here. Okay, can you imagine? So this is the humeral head. Okay, can you imagine that? So it catches the humeral head, okay, of the humerus. Now, it is positioned that way, the scapula is positioned that way because of the upper trapezius. Okay, remember the ideal posture for it to be elevated and slightly retracted. Now, if there is weakness of the or long-term paralysis of your upper trapezius, it will cause downward rotation of your scapula, protraction, and depression. What will happen to the orientation of the glenoid fossa? It will also go down. So if it goes down, it will be like this. Okay. So that will now affect the stability of the glenohumeral joint. Can you imagine? I'm just making my drawings exaggerated so you can imagine it better. But basically, it will affect the stability within the glenohumeral joint. And this may now cause, remember, you have a downward force coming from the gravity. Okay? So this may now cause inferior dislocation of the humeral head in the glenohumeral joint. Okay, I hope you can imagine it using my drawing. So this can be seen, for example, on patients with hemiplegia. Okay, flaccid hemiplegia, for example, due to stroke. Okay, that's why they may require sling in order to prevent this one. So this is just a picture of subluxation, inferior subluxation at the level of the glenohumeral joint due to paralysis of these muscles that we have discussed. Okay, so for example, paralysis of the upper trapezius. For the depressors of the scapulothoracic joint, we have your lower trapezius, your latissimus dorsi in the posterior view, and your pectoralis minor and subclavius in the anterior view. So let's first discuss your subclavius muscle. The subclavius acts as a scapulothoracic joint depressor indirectly, meaning it does not really connect with the scapula to perform depression. Because as you can see, if you are to review the origin insertion of your subclavius, it's not connected with the scapula. Instead, it is connected with the clavicle. So we can assume that if this contracts, it will only move the clavicle. But the thing is, since the clavicle is connected to the scapula through the acromioclavicular joint, if the subclavius contracts here, it will also perform depression of the scapula. So the muscle is actually, the force that it produces is actually almost parallel to the clavicle. As you can see, this is your subclavius. If it contracts, the force of direction will be this way. Okay, so it's almost parallel to the shaft of the clavicle. That's why your reference says that the action of the subclavius is actually, when it comes to depression of the scapula, is minimal. Okay, but its action is focused more on the stabilization of the sternoclavicular joint, because as you can see, if the subclavius contracts, it will kind of push the clavicle towards the sternoclavicular joint, therefore stabilizing the sternoclavicular joint. And as to the depression of the scapula, it has minimal contribution or small amount of depression torque to provide. Next, we have your pectoralis minor and your lower trapezius. So both your lower trapezius here and your pectoralis minor act directly on the scapula as depressors. Then lastly, here your latissimus dorsi, just like your subclavius, they act, or your latissimus dorsi act indirectly as a depressor of the scapula. So it depresses the scapula of the scapulothoracic joint primarily by pulling the humerus inferiorly. So if the latissimus dorsi contracts, okay, it will pull the humerus inferiorly, look at the arrow, and since the humerus is connected to the scapula, it will now depress the scapula. Okay, so please remember that subclavius and latissimus dorsi indirectly, they are scapular depressors, but for the pectoralis minor and lower trapezius, they are direct scapular depressors. For upward rotators of the scapulothoracic joint, we have the upper trapezius, lower trapezius, and the serratus anterior. So they act as a force couple to upwardly rotate the scapula. When we say force couple, it is formed when two or more muscles simultaneously produce forces in different linear directions, although the resulting torque or action or force will be in one or same rotatory direction. So in this case, okay, these different linear forces will result to one similar rotatory direction, which is upward rotation of the scapula. Okay, so specifically, the lower fibers of the serratus anterior that is attached to the inferior angle of the scapula rotates the scapula, specifically the glenoid fossa, in a upward and lateral direction. Okay, so the pull of the serratus anterior, specifically the lower fibers which attach to the inferior angle of the scapula, is directed laterally and upward. Okay, laterally and superiorly. Please remember, laterally and superiorly. Now, that is our first linear direction, or linear direction number 1. For the upper trapezius, it moves the scapula in an indirect manner because, as you can remember, in the original insertion, the upper trapezius is not really directly attached to the scapula. Instead, it is attached to the clavicle, but since the clavicle is attached to the scapula, it will cause motions in the scapula whenever the upper trapezius contracts. So the pull of the upper trapezius in the scapula is directed in a superior and medial direction. Okay, superior and medial direction. And lastly, your lower trapezius, okay, it pulls the spine of scapula in a downward and medial direction. So this is a video to show that. So the serratus anterior pulls the scapula in a, please don't use this one, please use this, okay, in a upward, and let's change that. So in an upward and lateral direction. So serratus anterior, upward and lateral direction, upper trapezius indirectly in upward and medial direction, and the trapezius in a downward or inferior and medial direction. Okay? Now, these linear forces, if these muscles contract simultaneously, these linear forces will result now to the rotatory force in the scapula, specifically the upward rotation of the scapula. Can you imagine? So this one, and this one, when combined, will cause upward rotation of the scapula. For the downward rotators, they also form a force couple just like the upward rotators in order to downwardly rotate the scapulothoracic joints. Okay, so we have your levator scapulae here with the following linear directed force. So upward and medial for the pectoralis minor, downward and medial, and for the rhomboids, slightly upward and medial. So the combination of these linear forces will now cause downward rotation of the scapula. Okay, so just like the one in the video. So again, we have your levator scapulae here, which is attached to the medial border of the scapula. We have your rhomboids minor, rhomboids major, and your pectoralis minor in the anterior part or anterior view. So the contraction of these muscles simultaneously will now cause downward rotation of the scapulothoracic joint. By the way, guys, whenever you review the motions of the scapula and the GH, and also as to what muscles are contracting during those motions, please browse your complete anatomy because they give better visualizations regarding those actions and motions. Now, for the flexors of the GH joint, we have your pectoralis major, specifically the clavicular head. Okay, then we also have this one. We also have your anterior deltoid. Well, they are located anteriorly, so if they contract, they will cause flexion of the GH joint. We also have your coracobrachialis and your biceps brachii. Again, pectoralis major, clavicular head specifically, your anterior deltoid, your coracobrachialis, and your biceps brachii. For the extensors, we have your latissimus dorsi, your posterior deltoid, your teres major, your triceps brachii, specifically long head, because the long head of triceps is the only head of the triceps that crosses the shoulder joint. The other two do not cross the shoulder joint, therefore they do not have action on the shoulder joint. And your pectoralis major, specifically the sternocostal head, which is located anteriorly. Okay, latissimus dorsi, teres major, posterior deltoid, well, they are located posteriorly, so if they contract, they will cause extension. Long head of triceps brachii and pectoralis major, specifically the sternocostal head located anteriorly. If it's the clavicular head of the pectoralis major, it is shoulder flexor. It is a shoulder flexor. For the latissimus dorsi, I want you to remember the mnemonic exadir. Extension, adduction, internal rotation. That is the action of your latissimus dorsi in the glenohumeral joint. For the abductors, we have three. So we have your supraspinatus muscle, your anterior deltoid, and your medial deltoid. If the deltoid is paralyzed, the supraspinatus muscle here is generally capable of fully abducting the glenohumeral joint, although the abduction torque will be reduced. If the supraspinatus is paralyzed or its tendon is completely torn, okay, the full abduction is often difficult but still achievable. However, for some persons, full abduction is not possible because of the combination of weakness and the impaired arthrokinematics of the glenohumeral joint already. And lastly, full abduction at the glenohumeral joint is not possible if both deltoid and supraspinatus are paralyzed. So again, abductors, we have your supraspinatus muscle, anterior fibers of the deltoid and medial fibers of the deltoid. For the adductors, we have your latissimus dorsi, remember exadir. We have also your teres major and your pectoralis major in the anterior view, specifically the sternocostal head. For the external rotators, we have the infraspinatus and the teres minor of the rotator cuff muscles and the posterior fibers of deltoid or posterior deltoid. As you can see, they are all located posteriorly, so when they contract, they pull the glenohumeral joint towards external rotation. For internal rotation, we have the subscapularis muscle of the rotator cuff muscles here. We also have the teres major, the latissimus dorsi, okay, on the posterior view. Remember the action of the latissimus dorsi in the GH joint is exadir. Then, lastly, we have the pectoralis major. Pectoralis major. Again, subscapularis of the rotator cuff muscle, teres major, pectoralis major, and the latissimus dorsi. For the next topic, we will be discussing movement and case analysis of the shoulder complex for us to apply what you have learned during the first part of the lecture and while browsing the handout and references given to you. First is movement analysis during shoulder elevation. When we say shoulder elevation, please think of abduction and flexion. So shoulder elevation through abduction, shoulder elevation through flexion, or shoulder elevation through abduction and flexion. Okay, so shoulder elevation is flexion and or abduction of the shoulder. So this is just a review because we have discussed this already. This picture just shows the posterior view of a healthy shoulder, showing the muscle interaction between your scapulothoracic upward rotators, which we have discussed a while ago, and your glenohumeral abductors that was also discussed already a while ago. Aside from the force couple produced by the upper trapezius, lower trapezius, and serratus anterior to perform upward rotation of the scapula and contraction of your supraspinatus muscle, middle deltoid, and anterior deltoid to perform glenohumeral abduction, there are other force couple happening in the scapular region for shoulder elevation to happen. So one is your posterior tilting. So aside from upward rotation of the scapula in the scapulothoracic joint, during shoulder elevation, there is also posterior tilting at the acromioclavicular joint. Okay, so posterior tilting happens between the serratus anterior and the lower trapezius. So the serratus anterior and the lower trapezius they act as a force couple in order to produce posterior tilting of the scapula while upwardly or during upward rotation of the scapula during shoulder elevation. So specifically, the serratus anterior pulls the scapula in an anterior and lateral direction, while the lower trapezius pulls the scapula inferiorly. Now, this force of direction and this force of direction will result to posterior tilting. Again, serratus anterior pulls the scapula anteriorly and laterally, while the lower trapezius pulls the scapula inferiorly and will now result to posterior tilting of the scapula in the acromioclavicular joint, while the scapula is upwardly rotating at the scapulothoracic joint during shoulder elevation. Okay, so aside from that, we also have your external rotation in the acromioclavicular joint. So your external rotation, as you can see, this is superior view, okay, is brought about by force couple happening between serratus anterior and middle trapezius, okay. So the serratus anterior contracts together with the medial trapezius to cause external rotation. Specifically, the serratus anterior pulls the scapula anteriorly and laterally. So this is the linear direction, while the medial trapezius pulls the scapula medially. So this is the linear direction, and the combination of those linear directed forces will now cause the rotatory movement of external rotation of the scapula in the acromioclavicular joint. Meaning, aside from posterior tilting, there is also external rotation of the scapula at the acromioclavicular joint when the scapula is upwardly rotating at the scapulothoracic joint during shoulder elevation. Okay, so during shoulder elevation, there is upward rotation in the scapulothoracic joint, posterior tilting in the AC joint, and external rotation in the AC joint as well. So aside from the supraspinatus and the anterior and middle deltoid contracting to perform abduction, there are also contraction of other muscles in the shoulder complex that should happen for an efficient shoulder elevation. Okay, specifically the subscapularis, infraspinatus, and teres minor. So by the way, these are your rotator cuff muscles. Okay, supraspinatus, subscapularis, infraspinatus, and teres minor. Let's first discuss your supraspinatus. So aside from abducting the glenohumeral joint together with the deltoid, your supraspinatus muscle also functions to superiorly roll the humeral head during abduction. Okay, please remember that. And at the same time, when the supraspinatus contracts, it compresses the humeral head towards the glenoid fossa, therefore increasing the stability of the glenohumeral joint during shoulder elevation. Last, it creates a semi-rigid spacer above the humeral head, restricting excessive superior translation of the humerus. Okay? Because during abduction, your deltoid actually the contraction of your deltoid can result to superior translation of the humeral head. And of course, we don't want that because if there is superior translation of the humeral head, it may hit this area, which is a bone, and we don't like that. And remember, there are muscles in this area as well. So we don't want stress in this area brought about by the superior translation of the humerus. Okay, so that is why also your subscapularis, infraspinatus, and teres minor should contract because the function of these muscles, okay, is to exert a depression force in the humeral head or on the humeral head during shoulder elevation, okay, especially to counteract the superior translation of the humeral head brought about by deltoid contraction during shoulder elevations. Example, during abduction. Remember, your deltoid abducts the arm. Okay, because again, if there is no downward force coming from the subscapularis, infraspinatus, and teres minor, the humeral head will go or translate superiorly because of the deltoid contraction. Okay, we don't want that. So the contraction of your subscapularis, infraspinatus, and teres minor will provide a downward force in the humeral head during shoulder elevation. Lastly, your infraspinatus muscle and your teres minor are also external rotators. So during shoulder elevation, there should be external rotation of the glenohumeral joint. Why? Because if the glenohumeral joint, so let's use this picture, okay, please look at here. If the glenohumeral joint abducts without externally rotating, look at this one. This is your greater tubercle. If it abducts, it will hit the acromion process. However, if it externally rotates during abduction, for example, at approximately 90 degrees of abduction, the supraspinatus and infraspinatus are externally rotating the humerus. the greater tubercle will not hit the acromion process because it will go posteriorly. Okay, compared to this view. Compared to this view. Okay, that's why it's also important. This one is application in physical therapy exercises. So if you are to exercise a patient and the exercise involves shoulder abduction, extreme shoulder abduction, so instruct the patient that at approximately 90 degrees of shoulder abduction, he or she should externally rotate the extremity, the upper extremity, so that the tissues attached to the greater tuberosity will not be impinged on the acromion process. Okay, so again, externally rotate the shoulder at 90 degrees of abduction or onwards. Please tell that to your patients in the future. Next, let's analyze when a person raises a dumbbell, just like in the picture. So first, identify the osteokinematics at the sternoclavicular joint, acromioclavicular joint, scapulothoracic joint, and glenohumeral joint, and identify the orthokinematics at the SE joint and GH joint, and kinematics at the AC joint and ST joint. Okay, so for the osteokinematics at the sternoclavicular joint, what happens during shoulder flexion at the sternoclavicular joint? Guys, your shoulder flexion is under shoulder elevation, right? So, at the level of the sternoclavicular joint, when doing this motion, there is elevation of clavicle and posterior rotation of the clavicle in the sternoclavicular joint. So, elevation and posterior rotation at sternoclavicular joint. For both the AC joint and scapulothoracic joint, there is upward rotation. Okay, for you to perform shoulder elevation, such as shoulder flexion, like this one, there should be upward rotation of the scapula, right? Both in the AC joint and ST joint. Then lastly, for the glenohumeral joint, this is shoulder flexion. Okay, so as to the planes of motion and axis of rotation, for the sternoclavicular joint during elevation, so that is frontal plane and z-axis. For transverse rotation, that is sagittal plane and x-axis. Then for the flexion at the glenohumeral joint, so that is sagittal plane and x-axis. Upward rotation happens in the frontal plane or scapular plane. Next, for the orthokinematics of the SC joint and GH joint and kinematics of AC joint and ST joint, let's proceed first with your sternoclavicular joint, okay? For the elevation, so that is, since this is open kinematic chain and the motion of elevation is happening on the frontal plane, therefore we can assume that it is the convex articular surface of the sternal end of the clavicle that is moving on the fixed concave articular surface of the clavicular facet of the sternum. Okay, with that we have to follow the opposite rule. So the convex articular surface of the sternal end of the clavicle rolls superiorly, so just follow the shaft of the clavicle. Okay, so during elevation, this is your clavicle, sternum. Okay, so during elevation, shaft goes superiorly, therefore the roll is also superiorly. So convex articular surface of the clavicle rolls superiorly and slides inferiorly. Why? Because it's the convex that's moving, so opposite rule, on the concave articular surface of the clavicular facet of the sternum. Okay, for the posterior rotation or upward rotation of the clavicle, it's just the clavicle spins in the articular disc of the sternoclavicular joint. Okay. For the glenohumeral joint, since this is flexion, if you can remember from our discussion a while ago, the arthrokinematics for flexion involves spinning. Okay, so the convex articular surface of the humeral head spins, and at the end range or extreme range of flexion slides anteriorly on the concave articular surface of the glenoid fossa. Okay, for the kinematics of your AC and your ST joint, this is upward rotation of the scapula. Identify the muscles acting on the shoulder complex and as to whether they are agonists, synergists, or antagonists. So for the agonists, we have your shoulder flexors, your anterior deltoid, coracobrachialis, biceps brachii as your agonist muscle. Okay, so because it is the main muscle that's contracting for the patient to lift the dumbbell. Next, for the synergies, it is your upward rotators. Okay, upward rotators of the scapula, because as you can remember, for the patient to perform flexion, there should be upward rotation of the scapula. So the upward rotators of the scapula should contract, such as your upper and lower trapezius and your serratus anterior. For the antagonist muscle, it will be those muscles acting opposite to the agonist muscle and to the synergist muscle. So we have your shoulder extensors, such as your latissimus dorsi and posterior deltoid, and your downward rotators, your rhomboid, pectoralis minor, and levator scapulae. As to the type of contraction of your shoulder flexors, we have concentric. Why? Because the muscle must contract, must shorten concentrically in order for the patient to lift the weight against gravity. Okay, to lift the weight up against gravity. Now, if the patient has to lower the weight from this position, going back to this position, it is still your shoulder flexors that are contracting, but this time eccentrically. Okay, so controlled movement of the shoulder from flexed position to extended to neutral. So that is actually shoulder extension movement, and there it should be facilitated by eccentric contraction of your shoulder flexors for the patient to slowly lower the weights, okay, or return the weights back to the first or initial position in a controlled manner. Because if the patient will use the shoulder extensors, the movement will be abrupt and it's not safe. We don't want that, okay? Next, placing the hand behind the head. So please try to imitate the girl in the PowerPoint, or please try to do this one, placing the hand behind the head, for you to better analyze the actions happening in each segments of the shoulder complex. So first, describe the motions required, identify the muscles involved, and describe the contractions done by the muscle. So let's proceed with analyzing the movements happening when you put your hand behind your head. Okay, first, okay, putting your hand behind your head involves, or it will result to shoulder elevation, right? So at the level of the sternoclavicular joint, there should be elevation of the clavicle and posterior rotation of the clavicle. Okay, for the retraction, since you have to put your hand behind your back, please try to do the movement. Okay, you will feel that your clavicle is actually retracting. Okay, for you to put your hands behind your head. Okay, so for the scapula, so that includes your acromioclavicular joint and your scapulothoracic joint. There is elevation and upward rotation of the scapula and scapular protraction. Lastly, at the level of the glenohumeral joint, there is GH elevation, so that includes flexion and abduction at the same time. and also external rotation. Again, please do the movement. You will notice that as you elevate your shoulder, you are also externally rotating your glenohumeral joint in order to place your hand behind your head. For the muscles contracting during these motions, first we have your serratus anterior and your trapezius, your specifically upper and lower trapezius, because they are responsible, remember, for upward rotation, right? Okay. At the glenohumeral joint, we also have your deltoid and your supraspinatus muscle. So your anterior and middle deltoid and your supraspinatus muscle for elevation of the glenohumeral joint. Then lastly, since you have to externally rotate also your glenohumeral joint, there is contraction of your infraspinatus and teres minor. Okay, so serratus anterior and trapezius for the scapular movements, deltoid and supraspinatus, specifically anterior and middle deltoid for the elevation. Then later there is also contraction of the posterior deltoid, but we will be discussing that in a while. Then infraspinatus and teres minor for the external rotation of the GH joint. As to the type of contraction, we have concentric contraction, okay, because we have to lift the hands and the weight of the upper extremity against gravity. Except the trapezius during scapular protraction, okay. Just to enable the scapula to just to enable the scapula to protract in a controlled motion during the movement. And also, the posterior deltoid contracts eccentrically as well during 0 to 60 degrees of shoulder elevation. Then eventually it shortens as elevation continues. So when you return the upper extremity to the side, so from the hand behind the head back to the initial position, you will just it will just produce these motions in reverse. Okay, so that includes depression, protraction, upward rotation, scapular depression, downward rotation, retraction, then extension, adduction, and internal rotations. So just reverse everything. But as to the muscles, same muscles will be contracting, because when you return your hand towards to the initial position, it should be, or it has to move in a controlled manner. Okay, you cannot do the movement in an abrupt manner. So it is still the same muscles contracting, but this time they are contracting eccentrically for the controlled motion as to returning to the initial position. Last, for movement analysis, we have pushing. So describe the motions required, identify the muscles involved, and describe the contractions done by the muscles. So you may use this table when answering for the movement analysis. So when you push an object, okay, the motions happening in the shoulder complex are, first, at the level of the scapula, we have your protraction. As you can see, you have to push forward, so you have to protract the scapula. Okay, and since you need to elevate the shoulder and the upper extremity, there is also upward rotation and elevation of the scapula. At the glenohumeral joint, for you to perform shoulder elevation, so you have to abduct and flex your shoulder. Remember, when we say shoulder elevation, that is abduction or flexion, or abduction and flexion of the GH joint. As to the muscles contracting, first, we have for the scapula, we have your scapular upward rotators and your elevators. Specifically, your upper trapezius and levator scapulae and rhomboids to a lesser extent for the elevators. Then for the upward rotators, we have your upper trapezius, lower trapezius, and your serratus anterior. For the action at the glenohumeral joint, it is your abductors and flexors that are contracting. So specifically for the abductors, we have your middle deltoid, supraspinatus, and to a lesser extent, your anterior deltoids. Then for the flexors, we have your anterior deltoids, coracobrachialis, biceps. Okay. Type of contraction, since you have to push the object forward, concentric. Okay, if you have to push the this one forward, concentric. Okay, but for example, you cannot push it forward anymore because it is connected in a wall. For example, this one. This is a wall. Okay, and there is no movement happening anymore. Or it's like you're pushing the wall. If you're pushing the wall, there will be no changes in the length of the muscles, okay? Even if you contract it, because you're not moving. You're just pushing the wall. So that is isometric contraction of these muscles. We are done with the movement analysis. Let's now proceed with your case analysis. First case analysis is muscle testing. So what muscle group are you testing in this picture? So the patient is in 90 degrees, shoulder flexion, then the physical therapist is applying a downward force in the distal humerus of the patient. So you may pause this video, then play it again once you have your answer already to know the correct answer. So for this one, the physical therapist is actually testing the strength of the shoulder flexors. Why? Because at this position, the patient is actively contracting his shoulder flexors. Why 90 degrees? Because this is the optimal length of the shoulder flexors. So if you are to test the shoulder flexors of your patient, this should be the position. Specifically of the upper extremity, it should be flexed at 90 degrees. Then now the resistance is over the distal humerus, just above the elbow joint, and the force, the direction of force of resistance should be opposite to the action of the shoulder flexors, which is downward. Okay, can you imagine? This is the force that the physical therapy provides is opposite to shoulder flexion force. The resistance should be in the distal humerus so that the patient will only recruit the shoulder flexors to maintain the upper extremity in this position. Because if the physical therapist will put her resistance here, the patient now, in order to maintain this position, the patient may recruit also the muscles in this area, such as your elbow flexors. Okay, and we don't like that because we only want to test your shoulder flexors. Clear? Next case, tight muscles. A female patient reported of difficulty in unsnapping or removing her upper undergarment, which involves this motion. Upon assessment, you noted of tightness of some muscles in the area, causing the difficulty in performing this motion. So first question is, what are the tight muscles? Second question, what is the role of these tight muscles in the case? And 3, if you are applying stretch on the tight muscles, towards what direction should you apply the stretch? Again, you may pause this video, try to answer the question first, then play it again to know the right answer. For the tight muscles, we have your shoulder external rotators. So specifically your teres minor and infraspinatus. Why? Can you please do this motion? Put your hands at your back, just below the scapula. Okay, if you have difficulty in performing that, what motion of the shoulder are you performing first? It's shoulder internal rotation, right? So meaning if you have difficulty in performing shoulder internal rotation due to tightness of the muscle, it's because the opposite or the antagonist muscle of that motion, which are your shoulder external rotators, are tight. Okay? The shoulder external rotators are very tight that you cannot perform shoulder internal rotation. Be mindful of the torsion. Tors talks about the muscle. External rotators, meaning the muscle that is responsible for external rotation. Sean, external rotation is the movement. Shoulder external rotation is the movement. Okay, so the tight muscles are your shoulder external rotators, specifically your teres minor and your infraspinatus. What is the role of these tight muscles? So the role of your shoulder external rotators in this motion, which is shoulder internal rotation, is antagonist. Okay, antagonist because they have the opposite action to the action required to perform this motion in the shoulder complex or shoulder joint. If you are to apply stretch on the tight muscles, toward what direction should you apply stretch? So for you to increase shoulder internal rotation and perform this action, you have to stretch the tight muscles. Again, our tight muscles are your shoulder external rotators. Therefore, if you want to stretch them, you have to stretch them on the opposite direction. So it should be apply stretch toward internal rotation to increase internal rotation and stretch the tight shoulder external rotators. Next, stretching exercise. So a physical therapist instructs the patient to perform self-stretching of the upper trapezius. How will the patient position the shoulder and scapula? Next question is, how about the neck? So again, pause the video, try to answer first, then play it again to know the correct answer. Okay, so the answer is first, scapular depression. Remember the action of your upper trapezius. One action of the upper trapezius is to elevate the scapula. So if you want to stretch the trapezius, you should position the trapezius in the lengthened position. Guys, if a muscle contracts, okay, if a muscle contracts, concentric contraction, the muscle is shortening. Concentric contraction, the muscle is shortening. If you want to stretch the muscle, you position the muscle in the lengthened position. You stretch the muscle. For you to be able to do that, you perform the action opposite the action of the muscle you want to stretch. So for this one, if the action of the upper trapezius is to elevate the scapula, then for you to stretch it, the force should be performing scapular depression. What about the neck? So for you to be able to further stretch the upper trapezius, you can position the patient's neck in cervical flexion, contralateral, lateral flexion, and ipsilateral rotation, just like this one. So for example, if you are to stretch the right upper trapezius, first you provide scapular depression. That is very important, either by a physical therapist or if it's self-stretching, this one. That's why the patient is holding on the table to promote the scapular depression. Next is combination of cervical flexion, contralateral lateral flexion, that is lateral flexion to the opposite side, so towards the left to stretch the right upper traps, and ipsilateral rotation or rotation to the same side you are stretching, so that it's right rotation or rotation to the right. So the combination of these movements will now stretch your upper trapezius muscle. Okay, so that's it for our shoulder complex recorded lecture. So these are the references I utilize in this PowerPoint. So my main reference will be your Brunstrom by Hugh Bloom and Bertotti, and the kinesiology of musculoskeletal system by Newman, and also Snell's clinical anatomy by Richards. So again, please utilize your complete anatomy atlas and models for better visualizations of the things we have discussed, and access Physio for more information regarding the shoulder complex. We still have another recorded lecture for this module, specifically the elbow region. So a recorded lecture to talk about the elbow region. Thank you so much.